I don't recall exactly, but at least 20 times more uptake with the tumors with the lutetium than there is with the octreotide. So it's not unusual to see new tumors, well, what appears to be new tumors on the therapy scan that was not seen on the octreotide scan. They're not new. It's just that we could not see them because the test was not good enough to start with. So who can benefit from this therapy? Any patients with a neuroendocrine tumor with somatostatin receptors. In order to see them, you have to do an octreotide scan, or better, a gallium-68 scan.
You just ask the doctor for the gallium-68?
Well, if you are already eligible with the octreotide scan, there's no point in doing a gallium-68 scan. But if for some reason on the octreotide scan, there's still some doubt, the uptake is not that good, and then you can go to the gallium-68 scan. And you might be some of the patients that have a better uptake with the gallium-68 scan. We'll talk about the Krenning score, but basically what it does is it compares the uptake of the tumors with the uptake of other organs that are normally seen inside your body. So if you have a Krenning 2, well, it's a scale from 1 to 4. A Krenning 2 is equal to the liver parenchyma uptake. If you have a Krenning 3, that's more than liver, less than spleen. And if you have a Krenning 4, it's more than spleen. And what it does is it helps us decide what is the degree of uptake inside, or it lets us imagine what is the degree of uptake inside of these tumors. Why is it important? Because you can never trust a nuclear medicine physician. If it says there's strong uptake, sometimes it's not that strong. Okay, it's just because he wanted to tell the others that his scan was good enough to be able to see these tumors. We've seen a lot of patients with strong uptake that we look at the images and we can barely see them. And it's very important to see some uptake in them, because the more uptake there is, the more radiation will get inside the tumors. We usually take patients with grade 1 or grade 2 tumors. So grade 1 is, I don't know if all of you ever heard about Ki-67. So basically, if you have a score of 0 to 2%, that's grade 1. If you have 2 to 20%, that's grade 2. Over that, that's grade 3. And usually, it doesn't behave as good as the other two ones with PRRT.
Maybe a question,
Yes.
because we had a question remotely. Do you do PRRT on patients who have more aggressive nets, i.e. Ki-67 of 30 plus?
Usually we, well, there's one thing. The first thing is that these tumors tend to be more differentiated than the other one with grade 1 and grade 2. So to start up with, they may not have the receptors at the surface cell. So that's the one, that's the first thing that we have to check with these grade 3 tumors. And they tend also to have very rapidly dividing cells. So even if we give you a certain amount of radiation, other cells may divide faster than we are able to treat the other cells. So we might not be fast enough to treat all of these cells. We did some treatments with grade 3, but it has a limited effect on the tumors. And I will show you an example later. So the patient has to have non-localized disease, or if it's localized, it has to be non-resectable. So if you have something that is in your pancreas, in your liver, in your bones, you might be eligible if you have receptors. If you have something that is wrapped around your mesenteric artery in your bowels, like if your surgeon tries to remove that, he will cut the artery, and then you have no more blood supply for your bowels. So usually the surgeons prefer not to cut through the artery. So that's when we get these patients. You have to be progressive or symptomatic. So if your symptoms are progressing, your disease is not getting larger. But if your symptoms are getting worse, even if the disease is not progressing, we might treat you as long as we have something that we can measure, like 5-HIA, 4 Carson syndromes. chromogranin A or anything that will help us prove that the therapy is working. You have to have progression under sandostatin LAR. So the sandostatin LAR has to be in. Or if you're not tolerant to sandostatin LAR, or you refuse sandostatin LAR, that's okay. We'll talk to you. We'll forgive you, and then we'll be able to get you in the study. Yes.
I'm just asking because a lot of people are asking to get off the drugs that are bothering them a lot, so for chemotherapy or yeah. But so your progressive disease criteria, is that have to do with the division of the cells, or why do you need a progressive disease?
All of the lutetium therapies given in Canada are under research protocols. So we have to measure something. So if the disease is not progressing and we treat it, how do we know that our drug is working? So that's the reason why we have to have progressive disease.
Just to follow up to Miranda's
Yes.
question, so if it were more in like sort of a hospital setting, that would not be as much a criteria, it's just more because we're doing right now as research.
Yes, yes. So, well, we would still need this. We would still need the G1, G2. We would still probably need this as well, because we don't want to treat somebody that has resectable disease and localized disease. The progressive or symptomatic, that would be to the discretion of the doctor. The sandostatin LAR, again, there would still be under the discretion of the doctor, but usually that's a drug that's relatively benign, and now they have similar drugs like somatostatin that are usually less painful. That's what they say. I've never tried it. You have to have adequate, and I put adequate because it's very subjective. There is no threshold that we won't do it. We will always weight the for and against for therapy. Bone marrow reserve and kidney function. What I call bone marrow reserve is that if you come in for a treatment and you have platelets at 50 and you receive like 5 rounds of chemotherapy before, like 5 different type of chemotherapies, and your bone marrow is filled with metastases, we might not give you the therapy because we have the fear of putting you in thrombocytopenia. So these are the things that we have to keep in mind when we decide who is going to get the therapy or not. And adequate kidney function. I know that most centers will only accept patients with a glomerular filtration rate of 50. Basically your kidneys are filtering 50 cc's per kilos per meter square, 1.73 meters square. Just remember 50 cc's. In Quebec City, we've done as low as I think 35, but we do dosimetry, so we adjust the dose according to the kidney function as well.
Maybe.
Yes, a bathroom break.
Yeah, maybe now is a good time. So
Yes.
we'll break. Let's say for around 5 or 10 minutes. Show you where the bathrooms are. You have snacks over here. No snacks for people remotely, unfortunately, but please take a break. 5-10 minutes. We'll be back. Thanks.
So we'll see with the amount of coffee that is taken, if that's because people are sleeping. Yes.
So I had a gout.
Mais en fait, chaque site a sa propre petite recette. Okay? On ne se communique pas entre autres, on ne s'aime pas. C'est juste que je pense qu'on a tous des vies différentes. Et comme je sais qu'à Edmonton, ils ont tous une vision que les plus petites doses plus longtemps sont peut-être plus bénéfiques que les grosses doses moins longtemps. Fait qu'ils sont en train d'étudier ça. Ça c'est leur approche à eux. Nous, on s'est dit, ben, pourquoi donner la même dose à une dame de 50 puis la même dose à 300. Fait que ça, on ne comprend pas ça. On s'est dit. Pour donner une idée, on a un patient qu'à cause de l'escalade de dose, de la dosimétrie, normalement on donne 200 millicuries. Ça, c'est le one size fit all. Tout le monde a la même dose à travers le monde pour le temps. On a un patient qui a son dernier traitement, parce qu'on ne peut pas augmenter de plus que 50% par traitement. Hein, ça, c'est notre règle. Son dernier traitement, il a eu 715 millicuries. Puis j'ai parlé à sa conjointe tantôt, puis elle a bien. Donc, on le suit, on va voir le suivi à long terme, comment il va. Mais lui, ses reins avaient une capacité de filtration incroyable. On mettait de la radiation, puis il ressortait tout de suite. Si lui, on lui donne 200 millicuries, comme tout le monde, ben, il n'y en a pratiquement pas qui va assez tumeurs. C'est pas que lui, on lui donne un bonus par rapport aux autres, c'est qu'il faut qu'on y en donne assez pour que ça reste à l'intérieur de ses tumeurs.
We've gotten 3 questions remotely. Maybe we could start with that. Yes. So we're back in mute. And I even have a recording now. That was a bit of a goof to start, but we've got a backup plan for that. So the first question, it's a bit longer, so I'll read it out. I don't know if you want to read it too, but initial 4-centimeter CNET was resected in 2002, diagnosed with ectopic Cushing syndrome in 2011. BLA in 2011, second CNET lung located in late 2011, initial 2002 tumor retested in 2016, and ACTH staining was observed. Current CNET is likely producing excessive ACTH levels of 172, norm 49. Would this therapy be a benefit versus a risky surgery? I don't know if you want to...
Yeah, I think I got a sense of it.
Okay.
It all comes down to the same thing. Do we have receptors? Can we attach receptors to it? And is it a therapy? Is it a tumor that we think we can resect or not? So if we have localized the disease, if we think that all of the disease can be resected, then we could go for surgery. But from my understanding, as soon as we have disease that it is outside of the origin site, then it's not resectable because it's considered metastasis. So then the next step would be to go with the PRRT. Not to attain a cure, but just to have symptom control or ACTH level down. They could go. You could still go for surgery, just for debulking. Like if it's a large metastasis, they could resect it just to decrease the ACTH level, but probably not to cure the patient because there's probably some other tumors or other cells elsewhere that are going to grow.
Okay.
But yeah, this patient should have at least a scan to see if there are receptors on these cells.
Okay. Next question. Can bone metastases shrink with PRRT treatment, or is it mostly soft tissue tumors that benefit?
Okay. So when you do a CT scan and you look at bone metastases, you can see 2 things. It's either a soft tissue lesion inside of the bone, or you see sclerosis. Okay, so if you see a soft tissue component, and then you give the treatment, that soft tissue component can go away. But most of the time it will be replaced by sclerosis. Sclerosis is the reaction of the bone, the healing of the bone where the tumor was. And that will never go away. It's a scar within the bone. So some of the time, people will have therapies and they look at the sclerosis, and the sclerosis has not changed, so they say, well, the therapy is not working. Well, it may be working. It's just that you just see the scar and the tumor itself. So both the tumors in the bone and other soft tissue elsewhere will respond to the therapy. It's just that we will not be able to appreciate it on a CT scan.
Okay. And then the last question. For a patient who is showing progression, do you see any benefit of having a gallium-68 to discover as yet undetected tumors and to determine change of treatment?
Well, the first thing is progression under what treatment? Progression under the lutetium therapy or progression under other therapies? That would be better if that patient could, or that person could precise this question.
Okay. I'll send him a note back to see if so clarify.
Yeah, to clarify a little bit.
Progression under which treatment, or
yeah, or progression under lutetium or another treatment.
Okay. Yeah. Great. Okay. Thank you.
So, a list of NETs that can benefit from the therapy. So, any GI neuroendocrine tumors, we often call them carcinoid. Lung atypical carcinoid also. If they demonstrate the somatostatin receptors, we can see that and we can treat them. Pancreatic neuroendocrine tumors. When we call about pancreatic tumors, we're not talking about adenocarcinoma. We do receive requests for treatment of adenocarcinoma because it's pancreatic tumors. Most of the time, it doesn't come from a surgeon or physician, but patients that are desperate to find something available for their cancer. You have to make the difference between these two types of cancer. So I don't know if you recall Patrick Swayze, he had the adenocarcinoma. Steve Jobs, the creator of Apple, had the neuroendocrine tumor. So we had Steve Jobs with us a lot longer than we had Patrick Swayze because the adenocarcinoma is very aggressive and it doesn't have the receptors. And even if it had the receptors, it grows way too fast for us. It would be considered a G3. So we don't have any effect on it. These pancreatic neuroendocrine tumors, well, I have a quick list. It's probably more extensive than that, but it can produce insulin like insulinoma, glucagon like glucagonoma, gastrinoma. It can be non-secreting, or any other hormones like we have the ACTH producing a tumor. We can treat also pheochromocytomas and paragangliomas. They tend to be a bit more tricky at the first treatment because they are full of hormones. So when we get the first treatment, we have to be very careful because of hormone crisis. The percentage of success on a location basis has not been well documented in the literature. So if you ask me, okay, I have a glucagonoma, I want to know what is the percentage of patients that will have response with a glucagonoma. The answer is I only have case reports. I can't tell you if in your case it's going to respond or not. We know that generally most of the neuroendocrine tumors, like maybe 80% of the pancreatic neuroendocrine tumors, will respond to the therapy. Approximately the same with the carcinoid, but on a cancer per cancer basis, I don't have that information. And to tell you a certain percentage for this type of cancer would probably be a lie and just based on gut feeling. So I can't really answer that type of questions. So we talked earlier about the cranial score. Unfortunately, it doesn't show very well. But if we look in the liver of that patient here, and we compare it to the spleen parenchyma, that's way higher. That would be a cranial 4 for this patient. So 4 is higher than the spleen. If we compare this one here It's probably the same as the spleen, but a bit less than liver, a bit more than liver, so that would be a 3. So, and if we look at the spine, because we should never see bones on an octreotide scan, that's probably grade 2. So that gives you an idea of what to look for. And why is it that important? It's because if we want a therapy to be effective, we really want enough dose to the tumors. So we talked about it earlier. So who cannot or may not benefit from it or may not work as expected? So anybody who has a negative octreotide scan or gallium-68 scan. So as I said earlier, if you have a negative octreotide scan, now there are gallium scans available. Just go for it, just in case we might have a false negative. If you have lesions that are FDG avid, so you have a PET scan with FDG, which is glucose, that shows you the rate at which the tumors are behaving or they are multiplying. These are aggressive tumors, okay? And if you have these and they don't show up the octreotide or the gallium-68, they don't show up on these scans or on the other scans, it will not respond to the therapy. So usually we see this with G3 tumors. G3 tumors, it's a very, very, very large spectrum. So it's from 30% to 100%. So if you have a 90% and a 25%, it's not the same kind of tumors. So if you're a G3, but you're very close to 20%, you might try it. So it's not a definitive no, but it's on a case-by-case basis. If you're pregnant or lactating, we won't treat you. Even lactating if for 2 months prior to the treatment, because you have a lot of receptors inside of the breast. So we don't want you to give you a breast cancer in addition to your other cancer. ECOG is a performance status that gives us a general idea of how you are able to function in your everyday life. So basically, if you have an ECOG 3, it's you're capable only of limited self-care, confined to your bed or chair for more than 50% of the walking hours. So if you're in that condition, we will probably not offer you the treatment because you will need a lot of help from people around you, and a lot of help means a lot of radiation given to your family or person taking care of you. If you are unable to provide informed consent, if you are unable to follow radiation safety restrictions. So when you receive therapy, you are emitting some of the radiation. Most of it is not dangerous to the people surrounding you. So the gamma rays are not dangerous. Only 10% of the disintegration or the radiation will be emitted. So it's equivalent of going around with a bone scan. Okay, so it's not a lot of radiation. The radiation that is dangerous for other people is the one that is usually staying inside of you. So that radiation can go outside of you if you pee or if you poop. Sorry for the terms, medical terms. That means that you have to be very careful. For men, I know it's difficult, but you have to sit to pee because you don't want to spread it around the toilet. You have to keep it inside of it. And you have to flush the toilet twice in order for all the radiation to go in. And we usually ask people for 48 hours to sleep apart if they're married or if they are with somebody. Just make sure that they don't give too much to other people. And you have to wash your hand very thoroughly with soap and water because you can't use a gel outside in the hospital because it's not a living thing. So you have to make sure that it's detached from the skin and goes inside of the sink. So these are the basic things that you have to do in order to decrease the amount of radiation that is given to people around you. So if you're not continent, that's an issue. Nephrostomy as well, because it requires a lot of handling of urine. If you're able to do all your work alone, we might consider it. But if you have to have a nurse or somebody else empty the bags, that's going to be an issue for therapy. And one of the reasons is that there was one incident in one of the centers in Canada where one of the nephrostomy tube leaked and there was urine everywhere, and that's called a major spill because of the radiation content. And the Canadian Nuclear Safety Commission got into it and it said, well, if you ever do that again, we're gonna come and close the center. So that's why we're walking on eggs currently. We don't want to annoy them anymore for that.
Maybe a couple of questions
Yes.
related to this. So I'll go back to the
other question.
yeah, the previous question was clarified. So for a patient who is showing progression, do you see any benefit of having a gallium-68 to discover as yet undetected tumors and to determine change of treatment? Progression is under Sando LAR 9, increased to 3 weekly cycle, more symptomatic.
Yes, that would be it's the indication to go for a gallium-68 scan or an octreotide scan. Any one of them is good for any of the research protocols. But if you have the choice, definitely go for the gallium-68 scan.
Okay. And then a second question. Gallium-68 can glow with inflammation since inflamed cells can have SSTR2 expressed. How does one differentiate between inflammation versus a net?
Yeah. Most of the time, it's the CT scan that will help us decide if it's inflammation or not, and the clinical information that is provided by the physician. So when we call inflammation, we talk about the lymphocytes. Okay, lymphocytes can show receptors at their surface. And if we look at this one here, I don't see it. Maybe another one later on we'll see it. But a lot of the time we'll actually see the needs of our patients with arthrosis. Yes, we do see it. So the location will help us. The underlying anatomy will help us on the CT scan of the PET-CT. So let's say you have pneumonia when you come in for your CT scan, for your PET-CT scan. And you had a CT scan about a month ago that showed progression, and that's why you are going for a gallium-68 scan. If we see that it just appeared, it's almost impossible that a tumor grow that fast. So that will give us information about whether it's inflammation or infection or tumor. So it's not 100% specific. That means that we're not always right, but it helps. Okay, so how do we do therapy? I'll talk about Quebec City, and I'll try to compare it to Edmonton because I used to work in Edmonton. Please forgive me if it's different now in Edmonton. But so usually what we do is each patients have blood work done early in the morning, and they see the doctor just to make sure that they are clinically fit to undergo the treatment. After that is done, and we have all the information available, we give the pre-medication. So pre-medication or co-medication is basically for you to tolerate the treatment in terms of nausea. Okay, so we have two different medications that we give in Quebec City. We give Densatron and we give dexamethasone as well. So this is given over a few minutes, and then we start the amino acids. So what are the amino acids? So usually when we give lutetium octreotide, most of it will go through your kidneys and go inside your bladder. But a part of it will be reabsorbed by your kidneys and go back in the blood work, and then go back in your kidneys, and then go back in the blood. So there's that loop that increases the amount of radiation inside your kidneys. So by giving the amino acids, what it does is that it blocks that loops. So basically, when it goes inside your kidney, then it goes outside your bladder while it goes into your bladder. So that decreases significantly the dose to the kidneys. Some patients will only see 10% increase in dose to the kidneys with that medication, the amino acid, but from the study that I've seen, it decreases up to 50%. So that's quite significant. So the lutetium-177 octreotide can be administered over a various amount of time. When I was in Moncton, we used to give it over an hour, and we were seeing what Jean-Monsieur Goya was doing in Quebec City. We were saying it was crazy giving it over 20 minutes. But now that I'm in Quebec City, I'm saying that they're crazy to give it over an hour. We give it in 20 minutes. So, I mean, both are okay. Maybe there's slightly less effect with an hour injection, but the main point is like between the 20 minutes and an hour is okay. So the lutetium itself, we start the injection after 45 minutes just to make sure that the kidneys receive enough amino acid to protect themselves. It's a clear liquid. It's less than 1 ml. It's very concentrated, but according to protocol, then we dilute it in either a 6 cc syringe, or it could be a 100 ml bag. It really depends on where you are. It can be given IV, so intravenously, or it can be intraarterially. Most patients will receive it IV. Those that have only metastases located inside the liver, we can suggest them to go with an intraarterial injection. So what we do is we ask a radiologist to take a catheter to go through your wrist or your groin and bring that catheter right at the artery that drains inside of your liver. What it does is that it brings the highest concentration possible of lutetium inside your liver, so your liver gets served first, and other sites get less of the radiation. So more radiation to the tumors because we think that all of the tumors are in there, and less to other sites, which could be normal organs inside of you. And so after the injection is done, we remove the catheter, and everything is the same as the other one. And when you leave, you get oral dexamethasone. Depending on protocols, it can be between 2 and 7 days. Why would we go for 2 and why would we go for 7 days? Usually most people will get 2 days to cover from nausea. 7 days would be for somebody who has a lot of bone disease or liver disease, who experience a pain flare following therapy. Usually we don't give it in advance. We just say, like, if you have a lot of pain, call us back. We'll phone your pharmacist. We'll get more, and we'll manage the pain. But that's a minority of patients that will experience that kind of pain. So what happens if my tumor releases hormones while we're being treated? Trust me, I'm a doctor. So most hormones have antagonists. If you have an insulinoma, let's say like a patient, well, short story. I had a patient from the United States coming in. He had metastatic insulinoma, but it happens to be an anesthesiologist also, who was not working as an anesthesiologist anymore because he was too tired to do his job. Instead, he was working part-time in litigation and malpractice. So the first thing he asked me when he was in my office was, what are you going to do if I have like an hormonal crisis? So it's a good thing I look at everything the day before. So we have antagonists, so insulin, we could get glucose, we could get glucagon, adrenaline, we have beta blocker, glucagon, we have insulin, and so on and so on. So we have a medication. Usually what we try to do is we want to have them on hand, on the floor, so we don't have to run everywhere to get it if we need it. If we have it, nothing will happen. If we don't have it, things will happen. So, knock on wood, nothing yet. So, but we're prepared. So usually it's one treatment every 8 to 12 weeks, 4 treatments total. We do blood work every 2 weeks between treatments. The reason why we do it serially, like every 2 weeks, is we want to see if your platelets will drop. So the platelets will be the first sign of bone marrow toxicity to radiation, and we want to make sure that everything else also is okay, because we want to make sure that when we order the dose that you're in tip-top shape to go for the treatment. We usually don't reevaluate the disease between treatments, and we don't do it before the 3rd month following the last therapy. And we don't do any hormonal measurements in between scans. We do measure chromogranin A at the time of each therapy, but we don't do anything in between. And the reason is if we have tumor lysis, then we'll probably have more hormones inside of the bloodstream. So we don't want to raise an alarm while there's nothing happening. So if we don't know about it, then no harm's done. So this is the kind of view you get from the 3rd floor Hôtel de Quebec. So this is very nice, especially in the winter. You have all the and yeah. So basically, it's like a Club Med. You're
colder.
a little bit colder. You don't have access to alcohol, but you do get some entertainment. And yeah, it's you. In the treatment room, you're paired with another patient. We do it first because of lack of space, okay? But also because it's interesting for you to talk to another patient and see what is their experience. And then people get a little circle of friends, and then when there's another new one coming in, then you get to teach them, say, okay, that's what's gonna happen. So you're helping us quite a bit. So post-therapy scans. Okay, I told you that it was impossible after the first therapy to get almost no disease after, but that's exactly what I'm showing you. So this patient, this is the first therapy on the left. On the right side is the 3rd post-therapy scan. So when we saw that, we said, oh my God, he's cured. We have a complete response. But the guy I had in front of me was losing weight, was gray, and he was not feeling well. And clinics, well, the patient never lies. So this patient, we had, let's see, an FDG PET CT done on this guy. And his disease was now FDG avid. He had dedifferentiated, and his tumor cells were now considered like a G3. So his tumor was progressing. So this is one thing that can happen. This is a worst case scenario, but we just want to make sure that, well, if things aren't getting too quick, too fast, it might be some, it's not because it's working too great. Sometimes it's because it's actually not working very good. So the Nether-1 study. In nuclear medicine, I don't know why, but we tend to do like retrospective study, very small studies that are not very powerful, but this time we did it. It's a very good study, I think. We still have to complete that study. I'm talking like I did it, but I did it. So it's a randomized, non-blind study. It's 229 patients. What they did was they compared the sandostatin 60 milligrams. Like, okay, let's rewind a little bit. So you are a patient, you have sandostatin 30 milligrams, you're progressing. What choice your doctor has? Either he prescribes you a high dose of sandostatin, or he just says, we keep you on sandostatin 30 milligrams and we give you lutetium therapy. So basically that's what they did. And it was 200 millicuries, it's a fixed dose, every 8 weeks. It was only gastrointestinal mets of the mid-gut, so basically small bowel neuroendocrine tumors. And they look at time to progression, objective response, overall survival, and side effects.
Is that the study in Quebec City?
No, that's not. We haven't completed yet. The only thing that we did in Quebec City yet is publish about the safety of the dosimetry.
Okay, but where's that?
European study. Yeah, it's in Europe currently.
Okay.
Yes. So in order to be inside of the study, the weakest point was that you had to show progression over the last 3 years. So you could have been progressing like 3 years ago, and now you have stable disease, and then you can get inside of the, for some reason, the disease did not grow for the last couple of months, and you would still be eligible for that trial. And as I said, this study is still ongoing, but it's interim analysis, so they already have data coming from it. So basically, this chart gives you, if you're on the left side, that means that the lutetium is better. If you're on the right side, is that giving you more cyanostatin is better. So basically, if you look at all of the groups, if they split it in different categories, you're always better currently on the left side. This is probably the best charts to look at if you want to have a sense of is it working or not. So on the left side is progression-free survival. So from the time you started therapy, is the time, well, they measure the time between your enrollment in the study and the time you start to progress. So after 30 months, less than 50% of the patient with lutetium progress. So they haven't reached a median yet at the time of this, they did this interim analysis. And in the sandostatin, they reached less than 10 months after starting the study. And the overall survival, we're already starting to see a trend that people that receive lutetium are surviving better. Will it keep that pace? We don't know yet. But
this is the trend.
This is a
That's from a partial study.
Yes, it's a trend. So it still needs to be confirmed, okay? But it's interesting nonetheless. So if we look at the response from the tumors to the PRRT, what we see is that, well, you remember that video? Only 1% of the patient got a complete response. So this is a very small number. It's actually only one patient complete response. Partial response is 17%. The other ones, they don't say if it's stable disease or progressive disease. So we don't have that data from that study yet in that small article that I had. But from what I see when we treat patients, we consider stable disease as a good response to the therapy. We include it as the same way as we see partial response or complete response. So by taking the stable disease inside of the as a good response, it gives us about 70%, 80%. Again, that's a gut feeling of people responding to lutetium therapy.
Can you clarify complete, partial, and objective response?
So complete response is no more resolved disease. Partial response is at least, I think, according to RECIST criteria, is 25%. 30? 30? Listen to her. So side effects from the therapy. So you can have side effects directly following the injection, or you can have side effects arriving home. Nausea and vomiting, usually people don't tend to have a lot when we give the therapy. They tend to feel it a little bit when you come home, and it's more like a seasickness. So they feel like floor is moving a little bit. I don't know if you can comment on that, if you had any...
For me,
No?
no,
Not really.
not so much nausea.
Okay.
It was
Well, our medication or our protocol are getting better at controlling nausea. We do have patients that will, for some reason, have one vomit, and that's it. And after that, they're okay for the rest of the therapy and no more nausea or vomiting. But and we haven't been able yet. We've tried several different medications, and it always happens 5 minutes following the infusion of lutetium. Most patients will not have any nausea or vomiting. They will do have decreased appetite for a couple of days following the therapy, so we'll talk about that a bit later. Diarrhea, fatigue, thrombocytopenia, It can come later. Anemia, usually it's very rare. Sorry?
What's thrombosis?
Thrombocytopenia is your platelets will go down a little bit. Yeah. And you like it? And basically, any of your cells inside your bone marrow and your blood can decrease a little bit. Those that are dividing faster tends to go quicker. Well, they go down quicker because they need to be replaced more often in your bloodstream. So the platelets, since they only stay in your bloodstream for about 7 days, then as soon as the bone marrow stops working, then we'll see a decrease in the number of platelets. And mild alopecia. Alopecia is loss of hair. For some reason, only women will actually experience it because they are more careful about their hair and the way they dress and everything, so they feel more about it. Men will not comment about it, even if we ask for it. Is it a real difference? Is it more perception? But it's a grade 1, so it's very, very mild. So what causes the fatigue following treatment? That was one question I had before that meeting. Fatigue as a symptom is a nightmare for a physician because it can be a lot of things. Here's a non-extensive list of causes for fatigue, different conditions. But if you look at that list, there are 2 items that are very interesting. One is pain that is persistent. So if you have more pain, you could be more fatigued. But the one that we are interested in, medication and treatments such as chemotherapy, radiation therapy, and PRRT goes into that category. So in order to understand why there is fatigue, we'll do a little bit of radiobiology. So your level of fatigue will vary, and we currently don't know why. Every time you receive radiation, a small amount of radiation or a large amount of radiation, you could technically go into 4 different syndromes. The first one is acute. The acute radiation syndrome is a prodrome. The prodrome, there are 2 different aspects to it. There's a neuromuscular and gastrointestinal. If you recall that, basically you have 2 different kind of symptoms that you can experience. Some people, instead of fatigue, will have agitation, apathy, headaches, and dizziness. Gastrointestinal, they think it's because the hydrochloric acid is increasing in the stomach. You get more nausea, vomiting, loss of appetite, and diarrhea. And the more you are exposed to radiation, the higher level of radiation you have, the more symptoms you'll tend to have. And the quicker the prodrome will occur and the longer it will last. There is a latent stage where these symptoms will go away, and then we'll get into the other ones. Most of the time, patients receiving PRRT stop there. There's not enough dose to go into the other syndrome. But I will just talk to you about it just because I'm here and have time to use. So there's a hematological syndrome. So the hematological syndrome, basically what it does is that when you receive 2 grade to the bone marrow or more, like up to 8 grades, you will deplete all of your cells inside of your bone marrow. So usually we don't get to 2 grades, but we can get very close to it. So that's why we see the platelets starting to decrease a little bit. And that's why we are scared. And we really want to make sure that we don't get these platelets going down too much. And that's why we'll tell you, like, if we see the platelets not coming back up, that's probably because we went too far in your treatment, that we have to stop the treatments. All that data, by the way, was collected from Nagasaki, Hiroshima, Chernobyl, and everything. So they followed these patients for a very long period of time, and they were able to gather that data. The gastrointestinal syndrome. Oh, by the way, for doctor or nurses present here, usually you can save somebody with a hematological syndrome with supportive care, like transfusion. If you give Neupogen, you cover with antibiotics. Usually you can save these patients. And technically you could do a bone marrow transplant, but there's a lot of the community is divided.
Gray area.
Yeah, it's a very gray area because it's very difficult to measure the precise amount of radiation you receive. Because if you go a little bit over 8 grades, then you get to 10 grades, which you gets you to the gastrointestinal syndrome, which depletes the cells inside your bowels. So what it does is that all of the cells that are responsible to get the nutrients inside of you and keep the water and reabsorb the water will not be replaced. So that you will shed them, and it will also allow the bacteria to get in. So that's usually not a good thing. And neurovascular syndrome is basically brain edema and everything. You will never get to that dose, even if we put, if you have a lutetium avid lesion like next to your skull. We treated patients with skull lesions. We never get close to that dose, so that's not an issue. So yeah, the question: if I have a large metastasis close to my spinal cord, will radiation cause harm? Oh, and by the way, the last part of that question is there anything I can do to alleviate fatigue? Usually dexamethasone help a bit with the fatigue, but most of the time there's nothing we can do about the fatigue. It will go away by itself, and there's nothing really we can do to speed things up. If I have a large metastasis close to my spinal cord, will radiation cause harm to it? The dose needed to cause harm to the spinal cord based on external beam radiation therapy, you have to receive more than 4 grays to the spinal cord over several days in order to reach that. And the radiation that we give in radiation therapy is way less than that, and it's spread over way longer period of time. As I said earlier, you have radiation inside of you for 49 days or more, so you receive a little bit of radiation every day for more than 49 days instead of a large amount of radiation over a few days. I have one question here. If a lesion has a high SUV, will it be more resistant to radiation? So first off, SUV. What is SUV? It stands for Standard Optic Value. That's probably what I'll need a little pen and yes, exactly. So think of yourself as a bucket of water. Okay. So 1 kilo of you is 1 liter. So we put a certain amount of radiation inside of you. So if we put you into a PET scan, okay, that one, if you take a measurement with a PET scan, it will be diluted perfectly inside of you. So if you take a measurement here, you get the same amount of radiation as if you take a measurement here or here or here. So the camera will do the same with you. If you're 70 kilos, it will consider yourself as 70 liters of water. But we know that we're not 70 liters of water. And some organs will take more radiation than others. So what the camera will do is it will measure the amount of radiation inside that little area that you're pinpointing, that tumor, and it will compare it to what it should be if you were perfectly mixed, okay, and diluted. So if there's 5 times more radiation in that region than what it should be if it was perfectly diluted, then it will be an SUV of 5. If it's 5 times less, it's 0.2. Now the next thing we have to know is, what are we looking at? Are we looking at an FDG PET CT, or are we looking at a gallium-68 scan? Because the FDG PET CT uses glucose, and glucose is usually related to the amount of mitosis that there is in tumors. The gallium-68 scan only tells me if there are receptors on the cell surface. So if I have an ISUV with gallium-68 scan, it only tells me there's a lot of receptors, and that's usually a very good thing. because we want a lot of radiation to go inside these tumors. But if I have a tumor that has a high SUV with glucose, FDG, then that means that that tumor is dividing very rapidly and uses a lot of energy in order to progress. That's usually a bad thing. So for that question, it really depends on what scan that patient had to determine if it's a good thing or a bad thing for the SUV. If it's high SUV with gallium-68, then it will probably respond. If it's a high FDG and low gallium-68, it will probably not respond to the therapy. So, yeah. Okay, so PRRT and dedifferentiated tumors. I had questions about can we treat these patients. So the first thing is, do these tumors still have receptors? If they do, then we can try lutetium therapy. But there was a study, which I don't have the, oops, sorry. So when we look at this here, that red line here shows you the difference between the grade 1 and grade 2 tumors, and what is above the red line is the grade 2, 3 tumors. So we have partial response, marginal response, stable disease, and we have progressive disease. So basically what it says that if you're above the red line here, you probably have more chances of having progressive disease even if we treat you with PRRT. So that's probably the issue that we have with the differentiated tumors. So that question, I just made it up for you because people will ask it someday. Is that I just did a gallium-68 scan and there's significantly more disease on than compared to my octreotide scan, or I just did a post-therapy scan of lutetium and there's significantly more disease that we can see compared to my octreotide scan I did before. This is not necessarily progression of disease, it's just that it's a much better tracer. And if there's a lot of numbers here, I just try to get you to the right data here. So indium DTP octreotide here is the octreotide scan. So this is the affinity. So the 20 that I had was referring to the 22. So the amount of concentration needed to saturate the receptors. And the gallium is 0.2. So there's a factor of 110, not 20, but 110. So you will need far less tracers with gallium-68 to find it and to see it than the indium octreotide. The trade-off is that because they modified a bit the molecule by increasing the affinity with the SST2 receptors, somatostatin type 2 receptors, they did lose a little bit of the affinity for the other tracers. So your tumors may, and those that have the type 2 will receive a lot more radiation, but if your tumor doesn't have type 2, we may not see it with gallium-68 or the lutetium treatment. So one little thing to reassure you, what happens if something happens to me while you're radioactive? So there's an organism, well, there's somebody in the department, the government, the Canadian Nuclear Safety Commission, that decides the number of radiation you can receive over the course of 1 year. So if you are a nuclear sector worker, such as myself, the technologists, radiologists, or other people working with radiation, you're allowed to receive a lot more radiation than the general public. The surgeons are not, the ER doctors are not. So if for some reason you receive a treatment and you're highly radioactive and you go to the ER, you may think, oh, nobody's going to touch me, nobody's going to take care of me. But there's a little something in the law that says if you want to do a heroic act, you can disregard that level. And it just happened about 2 weeks ago. A patient that had a perforated ulcer 24 hours following the treatment. It was totally unrelated to the treatment. It's just that one of the stenosis or his Whipple there was an ulcer right next to it. So the ER doctor saw the patient, the nurses, and everybody, and the surgeon operated on this guy. So it was not unsafe for them to do so, but they decided they could have said no because they probably got a bit more than 1 millisievert than what is allowed to the general public, but they decided to do it anyway. So be reassured, if something happens, we'll take care of you. Good. Questions, concerns, free insults? No? Okay. So, other questions?
Anybody remotely? If you have other questions, send them in by text.
You said you normally get the blood test done every 2 weeks.
Yeah.
So you don't live in Quebec City.
You don't have to be in Quebec City to do the blood.
Where you are, and they send it up
So
there.
they fax us the report,
Okay.
or we can look on the Dossier Santé Québec.
Okay. Good.
Just got a couple questions coming in.
Yeah.
If you had a resection 10 years ago and your Ki-67 was grade 1, should you have another biopsy?
Not this, well, in order to be selected for the treatment, or if it's only because they want to get the PRRT, the answer is no. We just need to prove progression of the disease. That's the only thing that we need, and we need the the octreotide or gallium-68 scan.
Okay.
There's a more specific list for doctor and nurses, like we need a scan that is less than 3 months old, and we'll look for surgical reports and everything. But that little, these things have to be sent by the doctor, not the patient.
Okay. Great. Another question, contact info for the doctor.
I will not give my personal phone, but usually what we try to do is to get the physicians to contact us, or the nurses to contact us. The first contact is usually easier handled that way because we don't have nurses. We have to do all of our general nuclear medicine stuff ourselves, and if we get phones like every hour from patients, I'm fantasizing on the number of net patients now. But I mean, it's a lot better if we get faxes coming in with all the information that we can look at it with, take our time to look at it and just answer the phone. But don't worry, when you get your first treatment, then you get to get my email, and then you'll have answer fast. Usually I try to answer within 24 hours.
Maybe I'll add a little note to that. So yes, answers within 24 hours are responsive, and then even let's say a scan that I've had and kind of forgotten about, and then someone reaches out to me and says, hey, things are looking good, type of thing. So not to throw in a plug, but definitely something I appreciated. Another question, in your case for
Pheochromocytoma?
Exactly. Can you give more information, please?
Okay, so pheochromocytoma are tumors arising from adrenal glands. They tend to secrete hormones like adrenaline. So patient will have these large masses, usually in the abdomen, and they tend to secrete quite a bit. And for some reason, they are very radiation sensitive, and they tend also to react to one of the drugs that we actually used to give. We will not give it anymore for these patients. They can react to dexamethasone and secrete even more hormones with dexamethasone. So we had 2 cases of patients that we had to give beta blockers in order to decrease the blood pressure and the heart rate during therapy because they were releasing hormones. But they are very radiation sensitive, so they're one of our best performers with lutetium therapy. Yes.
How many patients do you have in Quebec?
Currently under the
Yes.
under the protocol, currently I could give you the exact number right now. As I said, I was dealing with everything. Don't worry, everything is anonymized. There's no name in there. I guess it's 30 something.
Okay.
So we have 42 enrolled patients as of now.
Do you see many Americans?
Sorry?
Do you see many Americans?
We've seen a bit less than 10 patients. We don't get a preferred. Yeah, well, they're not VIP. They get the
Okay.
same spots as you guys do. We're just thankful that we have them because they do have to pay for their treatments, and that money helps us finance treatments for other patients here. So that's the way it works. Yeah. Yes.
After embolization, that embolization, you have to wait a while?
Yeah. Well, actually, it depends if you have progressive disease outside of the liver. So if you do blind embolization, you can't rely on the liver disease to see if there's progression or not following PRRT, because it was just treated. But if 3 months following the treatment you see progression in the liver, then you can use it again. If you have other sites elsewhere, then you can still do the embolization and use the other one as target lesions and do the therapy. Yes.
I was wondering if you have some patients where you're doing the radiosensitization, so you have the tumor.
We tried with some patients that had received radiation, not radiation, chemotherapy before with IFU, and to see if we could get a better response by giving a low dose and giving a radiation afterward. Again, I don't think there's any measurable improvement by doing so. So for now, we're just, I don't think it's going to be routine.
Are you only using lutetium or
Yep.
the Y90?
Sorry? No Y90. The issue with Y90 is that it's a lot more toxic to the kidneys. So we can't go as high with the doses as with lutetium. In Quebec City, compared to other centers, for those who come to Quebec City, you'll have a lot more scans than what you'll have in other centers. The reason is we do dosimetry. So right after your injection, you get under the camera, we measure the total amount of radiation inside of you, and then we do it on day 1 and on day 3. So that allows us to see how you excrete the radiation. And that dosimetry helps us decide what's going to be your next dose. And that's how we are able to either increase significantly your dose or lower your dose in order to preserve your organs if we think that you're receiving a bit too much. We went as low as 15 millicuries for a patient and as high as 715 millicuries for a treatment. And I can tell you that the 15 millicuries in that patient gave a significant amount of radiation to the kidneys, and the patient was very sick from the therapy. But again, the patient had very poor kidney function to start with, so probably 150 or 200 millicuries would have been very, very, very tough to handle for them. So, but that was the last case resort. They did improve following the treatment, but it's yes.
When you have this therapy, are you obliged to tell people that you have it?
Well, it depends if you like them or not. No, you're not. You're not obliged to tell them.
If you go through residence.
The only thing that we ask you to do is that to consider everybody else like if it was a member of your family. That means that you are responsible for the other ones. So if you go on a bus and you're radioactive and there's an empty spot next to a pregnant woman and a baby in your hand, yeah, just stay away a little bit. Same thing if you crave a new movie that just came out to the theater, that's probably not a good time to go for a movie, especially if it's a trilogy that lasts for 6 hours. But you're not obliged to tell people. I would strongly encourage you to tell them to the Border Patrol. Tell the Border Patrol that you receive a treatment, because they will detain you for quite long if you don't tell them. The story about this is that one of the first patients that they treated that went across border in Edmonton, the radiation really looks, well, they don't have access to all the isotopes on their scanner, but the one that was closest to lutetium was plutonium. So if you try to go across the United States border with plutonium on yourself, probably they won't like it. So yeah, that patient was detained for close to 24 hours. But now they know about it, so it's not an issue anymore. From time to time they will call us, but usually it's not an issue.
I have a couple of remote questions. Will more patients be accepted? We all survive.
That's usually what happens when I'm stressed.
Will more patients be accepted from New Brunswick in the future?
Yes.
Yes.
Yes, well, it's not because I want, especially people in New Brunswick, to get NETs, but there is province has agreed to pay for every single patients that are coming from New Brunswick. So yeah, as soon as we see a patient from New Brunswick, it's no questions asked. If he's eligible, we treat them and we get paid. That's it.
Next one. Does this treatment work well for
Pheochromocytoma?
Thank you. And Paraganglioma.
Yes.
It doesn't seem to be talked about as much for it.
Yes, it does. Again, we need to see receptors inside of these tumors. If we do see it, well, if I see more receptors with MIBG, I then want to one MIBG than I do with lutetium or octreotide, I will try to favor MIBG because MIBG can technically be given across Canada. You don't have to come to Quebec City to receive it. So they will probably be a bit stressed about it, the physicians. They may be not accustomed to treat patients, so they will ask some questions to centers that are doing a bit more. But technically, it could be given to any centers in Canada. If it comes down to lutetium, then you have 3 centers. Maybe 4. I don't know if Toronto has started giving it yet, or Sunnybrook.
And then question for the doc. If I'm not from Quebec City and I need to do PRRT, how long is the stay for the whole treatment? And how many times do I need to come back to Quebec for the treatment?
So usually what we do, if you're from out of Quebec City, the first week of your treatment, you have to come in on Sunday night, okay, to be in the department on the morning, and you will do the GFR study. So we want to see your kidneys, how good they are at filtrating your blood. So that's only for the first treatment. The other treatments, you come in on the Monday night, and you get your treatment. It starts at 7:30 in the morning. So we have a list of places where you can stay for cheap. Okay, I think we have places you can. It's $35 a night. They can stay in specifically for patients that are receiving treatments in Hôtel de Québec. So you don't have to go to Chateau Frontenac at $350 a night. And they are very close by, so you can actually walk for your treatment to come in. Or if it's taxi, it's very, very close. So Tuesday you receive your treatment. Usually Tuesday noon you're still in the hospital, and that's roast beef Tuesday. So every single time it's roast beef. You'll get used to it. Don't worry. And then you have a scan in the afternoon, a scan on Wednesday morning, and a scan on Friday morning. Some people will decide to stay the whole week in Quebec City. Some people after the Wednesday scan will come back home and come back for the Friday scan. So if you decide to go back home on the Wednesday after your scan, you can always deal with the technologist to get your scan done a bit later on Friday. So they can come in the morning, so you don't have to stay in a hospital, or not in a hospital, but in a hotel on the Thursday night. And that's 4 times in the first year. So you have to do that. Yes.
Could it be more than 4 times?
Yes,
And
technically yes.
What
What makes us decide if we go with 5 or 6 or more therapies? So let's say you have a tumor that is very, 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 very intense on the gallium-68 scan and on the post-therapy scan. And your tumors has shrunk significantly following the first 4 therapies. We might be inclined to give you a 5th and a 6th one that we call consolidation therapy, just to give a little another boost, because we really wanted to respond as much as it can. If for some reason after 4 therapies it has decreased significantly in size, but now it's so small that we don't see the receptors anymore or as much as we would like a Krenning 2 or less, we'll leave it at that. We won't give you more therapies, we'll wait for it to increase in size. Because if we give you another therapy, most of the dose will go to your kidneys or other organs. So that's why we won't treat you. And if you have stable disease but still very intense, again, we'll keep it that way until we have progression on CT scan.
Maybe 2 more questions remotely. Does that mean MIGB is the preferred method for, thank you, Pheo than PRRT? Or would you still recommend PRRT for Pheo and Para?
We haven't seen any studies comparing both, so it's very difficult to know which one is going to be the best. What I do recommend is having both tests done. So octreotide scan and MyBG. And if you have a lot more lesions showing on one of the 2 tests, it's probably the best one to use in order to treat the cancer. If both are equal, it really depends if you have access to MyBG. If it seems to be a hassle in your hospital, because I know some places will, well, it's difficult for some places, then lutetium therapy might be a way to go.
Then last question here. Can we do PRRT scans in our own city, or does it have to be done only in Quebec?
Yes, it can be done anywhere. So octreotide scans can be done anywhere. And we just have to have the CDs or DVDs sent to us in order to review the images.
Potentially, the question was potentially about the scans. You mentioned scans during the week of therapy.
No, because all cameras have to be calibrated in order to do the dosimetry, because we have to know the exact amount of radiation. So even in our department currently, there's only 1 out of 3 cameras that is calibrated in order to do so.
Okay. So the scans during the week of treatment, that's always in Quebec?
Yes, always in Quebec City.
Other scans can be done in your local hospital?
Yeah, like the scans that you need to do for recruitment or the scans that you have to do for follow-ups. Usually we try to get them done in the same center every single time so that we don't have comparison issue, exactly. So
you're going to be doing this for years then, eh? So
yeah,
I just want to know, right?
Yeah, apparently. Yeah, so at least 25 years.
Okay.
Well, or unless there's something else bigger and better coming.
Okay.
So maybe we'll call it to a close. We can still stick around and mingle for a bit, but definitely wanted to say a big thank you to Dr. A lot of questions, and we really appreciate the answers. So on behalf of the people here, and also on behalf of the people remotely as well, I saw a lot of questions coming in. So big thank you. We really appreciate that. We have just a tiny little keepsake just to remember the zebras that were here. So we really appreciate you coming in here and helping us out. So thank you very much. Thanks. Thanks everybody. And a lot of thank yous coming in remotely as well from a lot of different places.